It's time for another 3-question warm-up. Let's get going. First question here, what drug categories have the following endings? So the first one is going to be alol. Those are going to be your beta blockers. Oxin is going to be the cardiac glycoside digoxin. Pril is going to make you think of ACE inhibitors. Tadine are going to be your H2 blockers. And then tropin in general is going to refer to pituitary hormones. Next question. Which alpha adrenergic antagonists are used in the treatment of pheochromocytoma? And that's going to be probably either using phenoxybenzamine or phentolamine. Next, why do the kidneys retain fluid in heart failure patients? Well, basically you have renal hypoperfusion. It's going to lead to activation of the renin, angiotensin, aldosterone system. So if your heart isn't pumping, you're underperfusing that kidneys, and then the JG apparatus recognizes that and secretes renin. Renin converts angiotensin to angiotensin 1, and then ACE is going to convert AT1 to AT2, and then that AT2 is going to signal the adrenals to secrete aldosterone, and then that great aldosterone is going to cause those kidneys to reabsorb sodium and then water. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about bones. We'll start by reviewing how bones are formed, and then we'll focus on the different kinds of bone tumors. Now, there are a couple of basic mechanisms by which bone is formed, which are called endochondral ossification and membranous ossification. Endochondral ossification is where chondrocytes lay down a cartilage frame for the bone first, and then the osteoblasts and osteoclasts come in and they sort of lay down the bone matrix later. This occurs mainly in the axial skeleton and in the limbs. And you know that children have epiphyseal plates on the ends of the long bones to allow the bones to lengthen. That's an example of endochondral ossification. Then sometime in adulthood, those plates fuse and the bones can't grow any longer. And then membranous ossification is where the osteoblasts and osteoclasts build the bone directly without that cartilage frame. This occurs in the skull and the facial bones. If there's a defect in the endochondral ossification in those long bones of the axial and appendicular skeleton, that's achondroplasia. This results in short limbs with the proximal segments of the limbs being shorter than the distal segments. The limbs are also disproportionately smaller than the trunk, and the head is disproportionately large. These individuals also have frontal bossing or a prominent forehead, and you can often see bowing of the tibias. Achondroplasia is caused by activation of a fibroblast growth factor receptor called FGFR3. It's a gain-of-function mutation, which means that instead of the mutation causing a protein that's unable to do its job, the protein has enhanced function or a new function. It's gained a function. In this case, the gain of function is that the growth factor receptor is constitutively activated, which means it's always switched on. That activation inhibits chondrocyte proliferation, so they don't lay down those cartilage models of the bone correctly. Now, the majority of these mutations occur sporadically, and they're associated with advanced paternal age. So the older the father is when they have a child, the more likely that child is going to have achondroplasia. Now, individuals with achondroplasia have normal life expectancy and normal fertility. That mutated FGFR3 gene, even though it arose sporadically in the father, can be passed on in an autosomal dominant fashion. So let's think through the genetics of this. Let's let big A be our autosomal dominant mutation that causes achondroplasia. So what gene was that? FGFR3. So big A is a mutation and little a is the wild type, the non-mutated gene with average height. If an achondroplastic patient has a child with a spouse that has a normal stature, what's the likelihood that their child will have achondroplasia? So we have to assume that the achondroplastic spouse is heterozygous for the mutation, so there's a 50-50 chance of passing on that mutated gene and having an achondroplastic child. But if you have an achondroplastic couple who had a child, so mom and dad both have achondroplasia, what would be the likelihood of having an achondroplastic child in that scenario? So again, assuming that the parents are both heterozygotes, there would be a 25% chance that the child would have normal stature and would not be affected. There would be a 50% chance of the child being heterozygous and therefore achondroplastic. And there would be a 25% chance that the fetus would be homozygous for the mutated gene and would therefore die in utero. That's why it's pretty safe to assume that both of these parents were heterozygotes to begin with, because homozygotes don't survive. So although fertility is not necessarily affected, when you have two patients with achondroplasia wanting to have a baby, there's a 25% chance that that fetus will be homozygous and is going to die in utero. 2/3 of the babies born to these couples will be achondroplastic. And when an achondroplastic woman is pregnant, we generally deliver by C-section, because if that baby is a normal phenotype,
The mom's pelvic outlet may not be wide enough to accommodate the baby, so deliver by C-section. I also want to review some basics on how bones heal following a fracture. This has shown up on Step 1 in recent years. We can think about bone healing in 3 phases, although there's a lot of overlap, so it's not quite as cut and dry as this table makes it seem. The first phase of bone healing is the inflammatory or reactive phase. In this phase, there's a hematoma that forms, and then osteoclasts move in to resorb 1 to 2 millimeters of bone on each side of the fracture. This takes a few days, which is why fracture lines often show up better on x-rays taken a week after the fracture rather than immediately after a fracture. And the space between the 2 faces of the bone is basically filled in with granulation tissue. And then multipotent cells from the periosteum move in and are converted to osteoprogenitor cells. The second phase is the reparative phase. This is where new blood vessels start to form outside the bone and then work their way in to provide nutrients to all those cells and to provide the minerals and things needed. And chondroblasts and fibroblasts move in and start to lay down cartilage and type 1 collagen to fill in the gap between the fractured edges. And eventually this cartilage starts to undergo endochondral ossification and becomes organized into what's called a callus. Then the third phase of bone healing is the remodeling phase. During the remodeling phase, that callus continues to become ossified, and then the new bone is extensively remodeled by osteoclasts and osteoblasts. We'll talk more about those cells in the next video.
Now let's talk about bone tumors. Most tumors that occur in the bone are metastatic tumors that originated somewhere else, like breast cancer or prostate cancer. We'll get to those later. But first I want to talk about primary bone tumors, which are tumors that arise in the bone or in the cartilage itself. You're likely to see questions where you have to recognize the tumor based on its appearance on x-ray and also its location. Now, make no bones about it. Bone tumors can be a little tricky, but I'm going to throw you a bone and give you some bare bones facts about each kind of tumor. Just the material you need to bone up on. I want to make it easy for you. No reason to work your fingers to the, well, you get the idea. Let's start with osteochondroma, which is the most common benign tumor of bone. It tends to occur in young males under 25. These look like big bone spurs with a cartilage cap on them. This is a benign growth of normal tissue in a normal location, which means this is a type of hamartoma. A hamartoma is a benign tumor of disorganized tissue in its normal location. You can have hamartomas in the lung, in the heart, and so on. So an osteochondroma is a kind of hamartoma of the bone. And fortunately, it's very rare that these benign osteochondromas become malignant chondrosarcomas. Next is an osteoclastoma, or a giant cell tumor of the bone. This is a tumor that contains multinucleated giant cells that resemble osteoclasts, the bone cells that break down the bony matrix. That's why it's sometimes called an osteoclastoma. But it's thought that these giant cells are derived from circulating monocytes that are recruited to the tumor and then sort of changed to resemble osteoclasts. Osteoclastomas occur in slightly older individuals, young adults ages 20 to 40. I'm old enough that I still consider 40 to be young. These are usually located on the distal femur or the proximal tibia, so near the knee. And you get something called a soap bubble appearance in the bone on x-ray. On this x-ray, down here in the proximal tibia, you can see this roundish lucency, which is the soap bubble appearance. It's a lucent lesion because those osteoclast-like cells are breaking down the bony matrix. And on the microscopic view, you can see the multinucleated giant cells and the mononuclear cells in the stroma. The next primary bone tumor I want you to know about is an osteosarcoma. Now, sarcoma tells you this is a malignant tumor. Osteosarcoma is the most common malignant primary bone tumor. It's less common than a multiple myeloma, but I don't really think of myeloma as a bone tumor per se. Myeloma isn't even really a tumor or a mass. It's a proliferation of plasma cells within the bone marrow. So anyway, the most common real primary bone malignancy is osteosarcoma. It's associated with the hereditary retinoblastoma gene mutation. Retinoblastoma is a malignancy of the retina, but individuals who have that mutation are also at risk of getting osteosarcoma. We'll talk about retinoblastoma again in the oncology videos. Osteosarcoma is most common in teenage boys, ages 10 to 20, and it's also seen in adults over 65. And then there are 2 x-ray findings you should know.
There's Codman's triangle, which is where the tumor pushes the periosteum up from the surface of the bone, forming this little triangular density on x-ray. And there's this classic sunburst pattern to the tissue, which is kind of pretty to look at, except it's a cancer that's going to kill you.
One last primary bone tumor to mention is Ewing sarcoma. Again, sarcomas are malignant by definition. Ewing sarcoma occurs in young boys under 15, and it's extremely aggressive. Ewing sarcomas tend to grow on the surface of the cortical bone, along the shaft of the long bones. And on X-ray, you can see this destruction and disruption of the cortex. And that disruption of the cortex gives this classic onion skin appearance with what looks like layers of an onion. And you should also know that Ewing sarcoma is associated with the 1122 translocation. All right, that's it for the primary bone tumors. And before we talk about metastatic disease to the bone, let's do a whiteboard review.
We've talked about 4 different primary bone tumors with a whole bunch of different patient populations and different X-ray findings and so on. So it's pretty easy because all you really need to know for step 1 are the buzzwords, but then you have to keep the buzzwords straight in your mind. So let's review these. First of all, which ones are benign and which ones are malignant? The benign ones are the osteochondroma, the osteoclastoma, and the malignant ones are the sarcomas, the osteosarcoma and the Ewing sarcoma. Then for the age groups, Ewing sarcoma seen in the youngest patient, under 15. Osteosarcoma, also seen in fairly young patients, ages 10 to 20. So the younger they are, the more likely they are to have a malignant primary bone tumor. And then for the osteochondroma, those are seen in patients less than 25, and osteoclastoma is seen in patients aged 20 to 40. And then for these radiographic appearances, for osteochondroma, that's the chunk of bone that's kind of stuck on the end of the bone, kind of around the knee. Codman's triangle is seen in osteosarcoma. The onion skin appearance is seen in Ewing sarcoma. Soap bubble was seen in osteoclastoma. And then the sunburst was osteosarcoma as well. Then one other thing to help you remember these X-ray findings. A student sent in this great mnemonic. The S and C in osteosarcoma reminds you of sunburst and Codman's triangle. Then the CH in osteochondroma reminds you that this one is a chunk of bone that's stuck on to the surface of the affected bone. And then the CL in osteoclastoma, CL is for clean, like soap makes things clean. So the soap bubble appearance is seen in osteoclastoma. And then for Ewing sarcoma, some students like to think about eating chicken wings and onion rings, which is a pretty good mnemonic, but it also makes me hungry. All right, very good job on these. And as your reward today, I'm going to give you a gold star made out of gold stars. Primary bone tumors are relatively uncommon. The majority of tumors you find in the bone are metastatic tumors. They started somewhere else and then they metastasized to the bone. So what kinds of mets are we talking about? Well, students sent us a good mnemonic for these. Permanently relocated tumors that like bones. The P is for prostate, the R is for renal cell cancer, the T's in tumors and that stand for 2 things, testes and also thyroid. The L is for lung and the B is for breast. So lung cancer and breast cancer love to metastasize to other organs like the bone, also the brain and the liver. And then also note the genitourinary association here. Prostate, testes, and renal cell cancer all like to go to the bone. Now clinically, it's important to know that some of these are lytic bone lesions, which means they're breaking down the bone at the site of the mets, kind of like we saw with osteoclastoma. And then some bone mets are blastic. They actually build new bone, but that new bone is disordered and weak and it fractures easily. So renal cell carcinoma mets and thyroid cancer mets to the bone tend to cause lytic lesions. Prostate cancer causes blastic lesions. And then breast cancer mets and lung cancer mets to the bone can either be lytic or blastic. And what are the clinical manifestations of bone mets? How are they going to present? Well, you can have bone pain. You can have epidural spinal cord compression, where a tumor in the vertebral body invades the epidural space and compresses the thecal sac in the spinal cord, which causes pain, sensory deficits, motor deficits, and bladder or bowel dysfunction. And then lytic bone mets cause hypercalcemia from the destruction of the bone. And now it's time for the end of session quiz. So pause the video, work through those questions, then restart the video and we'll go over them together.
First question. Where does new bone formation take place in growing long bones? Well, it takes place at the epiphyseal plate, where cartilage is being formed, and then that cartilage is transformed into bone. Next, Which primary bone tumor fits each of the following descriptions? The most common malignant primary bone tumor of children is osteosarcoma. Multiple myeloma, if you're going to count that as a bone tumor, is a disease of the elderly, not children. So osteosarcoma is most common. The most common benign bone tumor is an osteochondroma. 1122 translocation is associated with Ewing sarcoma. The retinoblastoma mutation is associated with osteosarcoma. Sunburst pattern on X-ray is an osteosarcoma. A soap bubble appearance on X-ray, remember soap is clean, so that's an osteoclastoma. And then onion skin appearance of the bone, wings and rings, that's Ewing sarcoma. May actually be a hamartoma, is osteochondroma. Remember, that's that chunk of bone and cartilage just stuck on the end of a bone. And then Codman's triangle on X-ray is osteosarcoma.
And the last question, what mutation leads to achondroplasia? It's a gain of function mutation on FGFR3, fibroblast growth factor receptor 3. And that's all for now. I'll see you next time.